Radical cystectomies are performed for muscle-invasive and high-risk or recurrent non-muscle invasive bladder cancer. This is a major operation with significant mortality and morbidity, with overall complications happening up to 64% of the time. Cardiopulmonary exercise testing, or CPET, is a method of assessing cardiorespiratory function and reserve. The anaerobic threshold, or AT, is the point at which anaerobic supplements aerobic respiration to produce energy. This appears to correlate with perioperative outcomes. CPET has been adopted increasingly for perioperative risk assessment and non-cardiac surgery prehabilitation. This study aims to identify whether the introduction of CPET resulted in delay to surgical intervention at our institution and also compares patient outcomes. A prospective radical cystectomy database was maintained for John Hunter Hospital. A 2-year retrospective analysis from 2018 to 2020 included 38 patients. Of these, 15 had CPET, which was introduced in December 2019, and comparative analysis was performed. The mean time from diagnosis to cystectomy was 95 days in patients who did not have CPET compared to 110 days for those who did, with comparable rates of neoadjuvant chemotherapy at 62 and 64%. The impact of COVID-19 on elective surgery bookings in 2020 was assessed, but found to have no statistically significant difference. The average length of stay was 18.6 to 13.8 days, favoring the CPET group, which also had a lower 30-day readmission rate, at 13 compared to 21%. Overall, 90-day mortality, all-cause specific, was 10.2%, and all of these patients either had aggressive undifferentiated variant pathology or were upstaged at cystectomy to at least nodal metastatic disease. Kaplan-Meier analysis demonstrated a non-significant difference of 59 compared to 43% survival at 35 months. Within the CPET group, the mean anaerobic threshold was 11.8 mL per kilo per minute, and 8 patients had a preoperative AT of less than 11, with a range from 6.3 to 10.5. Of this lowest tier AT subgroup, 50% had Clavian-Dindo complications of grade 2 or higher, and a 90-day mortality rate of 37.5%. The introduction of CPET did not cause significant clinical delays to surgery in our local health district. Patients who had CPET appeared to have a shorter length of stay and lower readmission rates. However, this does raise the possibility of some degree of selection bias, as a formal interventional prehabilitation program was not yet established for this population. The beneficial difference may be attributable to a small cohort and other confounders. However, it was clear that CPET was a valuable risk evaluation tool, and those with AT of less than 11 had higher morbidity and mortality rates.